Let's talk about prostatic disorders now. Prostate is an extremely important topic from the point of view of the entrance exams because invariably in all entrance exams there's at least one question from prostate, and also from the final year point of view where a lot of short notes can be asked from this module as well. So before we start talking about the actual disorders, let's talk about the anatomy of the prostate gland, because a lot of surgical anatomy correlates I'll cover here, which you will understand as I discuss the disorders later on. So McNeil was the person who described the anatomy of prostate, and he described three zones in the prostate. He described the central zone, the peripheral zone, and the transitional zone. Now, the central zone and the transitional zone, both of them have short unbranched glands. So these have short unbranched glands. Both central and transitional have short unbranched glands, whereas the peripheral zone has long and branched glands. Peripheral zone has long branched glands. And another thing which you need to know is that transitional zone is the one which is most commonly involved in benign prostatic hypertrophy. You know, there are two main conditions in prostate. One is benign prostatic hypertrophy, the other one is cancer. Now, if you look at this transitional zone, this yellow one here is the transitional zone. Okay, this is the transitional zone, and you can see that it is closely associated with the urethra. This pink structure passing through is the urethra. So the importance is that when this transitional zone is going to increase in size in BPH, it can compress the prostatic urethra, and that is what is going to lead to a lot of symptoms which we'll talk about later. The lower urinary tract symptoms which we'll discuss later is because this urethra is getting compressed by the central zone. The peripheral zone, this green one is the peripheral zone, right? So this green one is the peripheral zone. So you can see a lot of the peripheral zone is lying behind the urethra, prostatic urethra. And this peripheral zone has long branch gland, and this is the most commonly involved zone in cancer. This question has also been asked. So most commonly involved zone in cancer is the peripheral zone. The central zone, you can see this dark green one is the central zone, and central zone lies behind the prostatic urethra. Okay, so central zone, majority fluid, lies behind the prostatic urethra. So these were some points, few more points which I want you to know. So what happens is, there is a condition known as BPH, and the surgery for BPH is known as TURP. TURP is transurethral resection of prostate. Resection of prostate. We'll talk about this later. So in TURP, what is done, that the surgeon is going to remove the central zone. Central zone is removed. The transitional zone is removed. And majority of the peripheral zone is removed. Okay. But what is happening, that some bit of the peripheral zone is still left behind. And if some bit of the peripheral zone is still left behind, that means a patient can develop prostate cancer even after TURP. So that is a very important point to know, that a patient can develop prostate cancer even after TURP. Now, another thing which I want you to know, that as the transitional zone, as this transitional cell zone grows in BPH, it compresses the central and the peripheral zone into a false capsule, right? So this is a false capsule which forms. So this false capsule is going to be there, and outside the false capsule, Outside the false capsule, you have the true prostatic capsule as well. you have the true prostatic capsule as well. Right, so outside this false capsule is the true prostatic capsule also. Now, between the false and the true capsule, between the false and the true capsule, between this lies the prostatic venous plexus. Lies the prostatic venous plexus. So between the true and the false capsule lies the prostatic venous plexus, and the significance of this prostatic venous plexus is that this can bleed during surgery. This can bleed during surgery. So that is another important thing which you need to know, that the prostatic venous plexus lies between these two capsules. Now another thing which you need to know, the nerves, the nerve bundles which are responsible for erection, the nerve bundles which are responsible for erection lie posterolateral to the capsule. Lie posterolateral to the capsule. So what is the significance of this? Supposing the patient is undergoing a radical prostatectomy. Supposing the patient is undergoing a radical prostatectomy for prostate cancer, these nerves can get injured, and if these nerves get injured, then erectile dysfunction can occur. Right? Erectile dysfunction can occur. That is why when I talk about radical prostatectomy, I will tell you that these days we are doing the nerve-preserving radical prostatectomy. So we try to save this neurovascular bundle so that patients don't suffer from the erectile dysfunction. Now, two more things in the anatomy and then we move on to the actual conditions. So if you understand that this is the bladder neck, this is the bladder neck, and below the bladder neck you'll have the prostatic urethra. Now there is muscle all throughout the prostatic urethra and also at the bladder neck. So this bladder neck, this area here, the bladder neck area, this closes during ejaculation. This closes during ejaculation, right? So because this closes during ejaculation, the ejaculate goes forward and does not go into the bladder. But what happens? But when TURP is done, I told you what TURP is, but when TURP is done, bladder neck can be rendered incompetent. Bladder neck can be rendered incompetent. And if this happens, then what is going to happen? The ejaculate, will it go forward or will it go back into the bladder? Yes, it's going to go back into the bladder, and this is going to give rise to retrograde ejaculation, which is the most common complication following TURP. Okay, we'll talk about it later as well. This is the most common complication following TURP. So retrograde ejaculation can occur. Patient will say that when during intercourse, no semen is coming out, and later on the semen comes out in the urine. So it goes into the bladder. Also, you need to know that the distal urethral sphincter, okay, the distal urethral sphincter is situated just distal to the prostatic urethra. This is the distal urethral sphincter. Distal urethral sphincter is just distal to the prostatic urethra. And while doing TURP, this can be injured. And if this gets injured, what will that give rise to? Incontinence. The patient won't know about urine sensation, urine can just come out. So it will give rise to incontinence. Which is why when we talk about TURP, and I'm going to repeat this again there is a bulge in the prostatic urethra. There is a bulge in the prostatic urethra. This is known as verumontanum. Very important term. This is known as verumontanum. And this verumontanum, and I'll show you in the video as well, this is the distal limit of TURP. We don't go distal to this, because if I go distal to this, then I can injure the distal urethral sphincter, and that will give rise to incontinence. So these were the points in the surgical anatomy which I wanted to cover. I'll reiterate them when we talk about the clinical aspects. Moving on to the next topic, I want to talk about prostatic stones. There was one question which was asked 3 years back in the exam from prostatic stones. So prostatic stones can be endogenous prostatic stones, or they can be exogenous prostatic stones. Exogenous are more common than endogenous. Endogenous stones are just 20%. Exogenous stones are the ones which come from the kidney or come from the bladder, whereas endogenous stones are formed in the prostate. They are formed in the prostate itself. And the composition of these prostatic calculi, that was the question which was asked. The most common composition is calcium phosphate. So remember, P for prostate, P for phosphate. Calcium phosphate is the most common composition. And if you remember, even when I was talking about salivary gland stones, I told you calcium phosphate are the most common salivary gland stones as well. So here in prostate also there are calcium phosphate stones. These are incidentally detected. These stones are incidentally detected during TURP, and usually they are asymptomatic. No management is required for these stones. Another question which was asked in the exam was regarding corpora amylaceae. So these corpora amylaceae are lamellated bodies. These are lamellated bodies found in prostatic tissue. Lamellated bodies found in prostatic tissue, and they are thought to be, the question which was asked in the exam, they are thought to be precursors for prostatic stones. They are thought to be precursors for prostatic stones. Okay. So this is regarding prostatic stones. The next thing which we need to talk about is acute and chronic prostatitis. So infection of the prostate is known as prostatitis. Now, acute prostatitis, the most common organism responsible for this is E. coli. And this is usually secondary to urinary tract infection. It is secondary to urinary tract infection. How will the patient present with this? The clinical feature, the patient is going to have fever. There's going to be perineal pain. There can be chills and rigors as well. And there can be dysuria because it can be associated with a urinary tract infection. If you do a digital rectal examination, DRE is digital rectal examination, you will see a tender, boggy prostate. You will see a tender, boggy prostate is what you will feel. No prostatic massage should be done. No prostatic massage should be done, because if you do a prostatic massage, it can lead to septicemia. So we avoid a massage. Gently you can do a DRE and see that there is a tender, boggy prostate. Urine culture can be done. Urine culture can be done, and urine examination is also going to reveal threads in the urine. There will be threads in the urine. The management, of course, is antibiotics. And you must have been taught by Dr. Ranjan in pharmacology that because of this prostatic capsule, remember I spoke about the prostatic capsule, because of the prostatic capsule, antibiotics don't penetrate the gland easily. Okay, antibiotics don't penetrate the prostatic gland easily, which is why antibiotics need to be continued for a longer duration. They need to be continued for a longer duration, and 2 to 3 weeks we need to give these antibiotics. We need to give these antibiotics for at least 2 to 3 weeks. So in order to treat this condition. So this was regarding acute prostatitis. Chronic prostatitis can also occur, and chronic prostatitis can either occur because of multiple episodes of acute prostatitis, or if acute prostatitis is not being treated properly. Okay, so chronic prostatitis, either repeated attacks, or if acute is not treated properly, then chronic prostatitis can occur. The clinical features of chronic prostatitis, there can be prostatodynia. Prostatodynia means that there can be dull pelvic or perineal pain which can be there. There can be dull pelvic or perineal pain with which the patient can present. There can be dysuria also in some patients. So that is how these patients will come to us. And to diagnose chronic prostatitis, this is again a question which has been asked in the exam. To diagnose chronic prostatitis, we do the 3-tube test. Right? This is also known as the Mears and Stamey test. So the 3-tube test is that the first voided urine you collect in a test tube, this is coming from the urethra. The second you collect, that is coming from the bladder. That comes from the bladder. Then what we do is, then we will do a prostatic massage. And when we do this prostatic massage, after the prostatic massage, when you collect the sample, you will see prostatic secretions or you will see threads. After the prostatic massage, you will see threads in the next sample, and you can culture these threads to get the diagnosis. Okay, you can culture these threads to get the diagnosis. The management is antibiotics. And because we have discussed it takes a longer time for antibiotics to penetrate, antibiotics are usually given for 4 to 6 weeks. And the usually used antibiotics are Ciplox, are ciprofloxacin, or trimethoprim. These are the antibiotics which are continued for 4 to 6 weeks in patients. Now, if chronic prostatitis is because of chlamydia, then doxycycline is used. And if the chronic prostatitis is because of trichomonas, then metronidazole is used. Metrogyl is used. So this was regarding chronic prostatitis. I want you to know regarding the 3-tube test which has been asked in the exam. Now, the two main conditions in prostate are benign prostatic hypertrophy and prostate cancer. Now, both these conditions can present with similar features. So what I am going to talk about now, I am going to talk about the workup of a patient with prostatic problems. And before we start talking about the investigations, I want you to know that these patients present with a specific set of symptoms known as LUTS. LUTS stands for lower urinary tract symptoms. Lower urinary tract symptoms can be of two types. You can either have voiding or obstructive lower urinary tract symptoms, or you can have storage or irritative lower urinary tract symptoms. This is important because this was asked in the recent INI CET exam. There was a question regarding lower urinary tract symptoms as well. Now, let's first talk about the storage or the irritative symptoms, and in that you have increased frequency. So, increased frequency, very important point is that this is the earliest and the most common symptom of benign prostatic hypertrophy. This question has been asked in the exam. This is the earliest and the most common symptom of BPH. Others can be nocturia, that means increased nighttime frequency of urine. Urgency. Urgency means that the patient will have a sudden urge to pass urine. And if the patient doesn't rush to the toilet, then the patient will pass urine before he reaches the toilet, and that is called urge incontinence. Nocturnal incontinence is when the patient passes urine while sleeping, or nighttime incontinence, that is enuresis. These are all the storage symptoms which are there. The voiding symptoms or the obstructive symptoms are hesitancy. Hesitancy means that the patient has to wait for a moment or two before the urine starts to come out. Narrow stream of urine. So that will be a very common thing which the patient will come and tell you, that the stream has become narrowed. There'll be intermittent stream. It starts and stops. Post-void dribbling. After the urination act has been completed, there'll be dribbling of urine which will be there. There'll be features of acute or chronic retention or a sensation of incomplete emptying. These are all the obstructive symptoms of lower urinary tract which you should know about. Also, incomplete emptying and post-void dribbling have also been classified as post-mictural LUTS, right? So incomplete emptying and post-void dribbling have also been classified as post-mictural LUTS. And the important thing here is that this post-void dribbling, this symptom does not resolve. This symptom does not resolve after TURP. So if a patient has BPH, and even if you do TURP, and if the patient was having post-void dribbling, that symptom will not recover following the surgery as well. Another thing which you should know, that obstructive features are more commonly seen in patients with bladder outlet obstruction. BOO is bladder outlet obstruction. Whereas irritative features are more commonly seen in neurogenic bladder. In neurogenic bladder, right? So this is what you should know for the exam regarding LUTS. You need to remember all the LUTS. They are very important for the exam. Okay. One thing which I want to cover here, which is very important, acute retention of urine. You know that if the patient comes with acute retention of urine, what do we have to do? In acute retention of urine, we need to put in a Foley's catheter. We've discussed Foley's catheters in the chapter on bladder disorders, or we do an SPC, a suprapubic catheterization. But there is another term known as chronic retention of urine. Chronic retention of urine. And what exactly happens in chronic retention of urine is what I want to discuss. And the management is also very important because this can be asked as a clinical scenario. So chronic retention of urine means when chronically more than 250 cc of residual urine is there. When more than 250 cc of residual urine is there, and because of this there is increased tension on bladder wall. There is increased tension on the bladder wall. That is why sometimes this is also known as a high pressure. This is also known as a high pressure urinary retention. This can also give rise to bilateral hydronephrosis. So there can be back pressure changes because we've discussed what hydronephrosis is, and because the bladder is so full, there are back pressure changes in the kidney, and this can also give rise to renal impairment. So the kidney function can be deranged in these patients. So what are the clinical features with which the patient is going to come? The clinical features will be, of course, there will be incomplete emptying of bladder. There can be overflow incontinence. Overflow incontinence means urine just dribbles out, but not the entire amount, just some amount dribbles out. There will be a palpable bladder, very important. There'll be a palpable bladder in these patients. So when you palpate the suprapubic area, you'll feel a bladder. And usually these patients don't have pain because they've become so used to this bladder being enlarged. It's chronic retention. And all of you know that, if you have to hold your urine for some time and if your bladder becomes distended, there's extreme pain. But in these patients, because it's become a chronic problem, pain is not there. Now, what is the management of these patients? So you have to do urgent catheterization. In these patients. You should monitor the kidney function tests because these patients can have increased blood urea. Urgent catheterization should be done. Also, you should know when there is rapid decompression. In chronic retention, that can also give rise to hematuria, right? There can be bleeding, there can be hematuria as well. So when we were residents, we were taught that if you get a patient with chronic retention, put in the Foley's, decompress, but then intermittently clamp it, right? Don't decompress all of a sudden, otherwise there can be massive hematuria. So keep on clamping in between so that major hematuria does not occur. Some amount of it can still occur even if you clamp. Now, one more thing which happens is that these patients have post-obstructive diuresis, right? So these patients can actually become dehydrated, or they can be dehydrated to start off with. Therefore, adequate fluids should also be given after catheterization. Adequate fluids should also be given in these patients after catheterization. So this was the management of chronic retention. You should know this scenario as a clinical scenario. This can be asked in the exam as well. So I've told you about the lower urinary tract symptoms, and now we are going to talk about the workup of a patient with prostatic disorders. There are two main prostatic disorders which we are talking about, that is benign prostatic hypertrophy and prostate cancer, right? So the patient will present with lower urinary tract symptoms and the patient will come to your OPD. When the patient comes to your OPD, what is the first thing which you will do in such patients? The first thing which you do is that you'll ask them to take down their pants and you will greet them by doing a digital rectal examination. Right? So the first thing which is done is a digital rectal examination. We have already discussed in the chapter on rectal disorders about digital rectal examination, and that we can feel the prostate anteriorly when we do a digital rectal examination. Now, when you do a digital rectal examination, if it is benign prostatic hypertrophy, it is a firm rubbery prostate. And the mucosa over the prostate is mobile. Whereas if you're suspecting cancer, then in cancer, it is going to be a hard nodular prostate. It'll be a hard nodular prostate, and mucosa overlying the prostate is fixed. So this is the first indicator with which you can know whether you're dealing with BPH or you're dealing with prostatic cancer. The second thing which we do in these patients, we order urine examination. Now, urine examination for these patients, you would do a urine routine microscopy. A urine routine microscopy would be done. Urinary glucose estimation should also be done. And if infection is suspected, then urine culture sensitivity should also be carried out in these patients. Then these patients, we order an ultrasound, right? We'll order an ultrasound KUB. KUB we've discussed is kidney urinary bladder. So this is an ultrasound which is focusing on the urological system. Now this ultrasound KUB will tell us the prostatic volume. What is the size of the prostate? It tells us about the post-void or residual urine which is there. It tells us about the amount of residual urine. It will tell me if hydronephrosis is present. And it can even tell me about lymph nodes if they are enlarged to a large extent. So this is what the information I will get from an ultrasound KUB. Now along with this, a very important test which is ordered is serum PSA. PSA, you know, is prostate specific antigen. This is produced in the prostate itself, prostate specific antigen, and this is a glycoprotein which can be measured in the blood. Now, the various things which can affect the PSA value, the most significant being the age, right? Most significant being age. As the person ages, the PSA value will keep on increasing. Now, you know that majority of the prostatic problems occur between 50 to 70 years of age. That's the age group when majority of the prostate problems will occur. So, in a 50 to 69-year-old patient, 0 to 3 nanograms per milliliter is considered as normal. This value can also be seen in patients with benign prostatic hypertrophy and in some patients of prostatitis as well. Okay. So if the value is between 0 to 3 nanograms per milliliter, and we are suspecting BPH, then we can start BPH treatment. Then we can start BPH management without doing a biopsy. So between 0 to 3 nanograms per milliliter, no biopsy is required. If you're suspecting BPH, you start with the BPH management. Now the problem starts if the value is more than 3 to 4 nanograms per milliliter. That's when the problem starts. Now this can be seen in patients with benign prostatic hypertrophy, or it can be seen in cancer, or it can be seen in prostatitis. Now, I've already told you the features of prostatitis. So, if the patient is having pain, if the patient is having dysuria, then we suspect prostatitis. And if prostatitis is there, we will start these patients on antibiotics. These patients are started on antibiotics. And after antibiotics, 6 weeks later, we repeat PSA. Okay, so it takes around 6 weeks for the PSA to come back if there is an infection, and once you repeat it after 6 weeks, then the PSA will come back into the normal range if it is truly prostatitis. Now, to differentiate between BPH and cancer, the investigation of choice to confirm the diagnosis, whether it's cancer or not, is a truss-guided true-cut biopsy. We've already discussed about true-cut or core needle biopsies in the breast module. I've told you it is a type of an incisional biopsy with which we can take cores and we can confirm the diagnosis. So this is how we will confirm the diagnosis in a patient and differentiate between benign prostatic hypertrophy and cancer. Now, regarding truss-guided true-cut biopsy, there are certain points which I want you to know for the exam. So this is how truss-guided true-cut biopsy is done. An ultrasound probe is put in the rectum and then we target the prostate. So question number 1 which I want you to know, that at least 12 cores are taken. at least 12 biopsies or 12 cores are taken. This question has been asked in various exams, and these cores need to be taken from the base, the mid part, the apex, medially and laterally from left and right side. So they are to be taken from the base, the mid part, the apex, and medially and laterally from the left and the right side. We have to take at least 12 cores when we are doing a truss-guided true-cut biopsy. So that is one point which I want you to know. And the complications when you do a truss-guided true-cut biopsy, you can have hematuria. There can be hematospermia, or there can be rectal bleeding. These are the complications of a truss-guided true-cut biopsy procedure, which is the investigation of choice. Now, another new thing which is mentioned in Bailey, and this is a potential question for your exam, there's one more type of biopsy which has been mentioned, that is known as the transperineal. That is known as the transperineal biopsy. And you can see in the transperineal biopsy that we go through the perineum and we are basically targeting the anterior lobe. So transperineal versus transrectal biopsy, if we have to do a comparison, transperineal biopsy is good for anterior zone. It is good for the anterior zone, whereas transrectal is good for posterior lobe. Transperineal biopsy, one more indication is when there is raised PSA and negative truss biopsy. If there's raised PSA and you have a negative transrectal biopsy, then also we do a transperineal biopsy in patients. But transperineal biopsy, the problem is that it has to be done under general anesthesia. There is less risk of infection because we are going through the perineum and not through the rectum. Transrectal biopsy, on the other hand, can be done under local anesthesia comfortably, but there is increased risk of infection. So these are the differences between a transperineal and a transrectal biopsy, which have been mentioned in Bailey, and you should know about them for the exam. So just to reiterate what we've done in the workups till now, I will just recapitulate that and move forward. We've done a digital rectal examination. We've done a urine examination, we've done an ultrasound KUB, and we've ordered PSA. Depending on the PSA value, if the PSA value is more than 3 to 4, we will carry out a biopsy for these patients. There are certain points regarding PSA which have been mentioned in Bailey and in Smith's urology textbook, which I want you to know. PSA is not affected by digital rectal examination. Free PSA is more sensitive. So if there is a reduction in the percentage of free PSA, that is indicative of cancer. PSA velocity means the change in PSA with time. PSA velocity is the change in PSA with time. More than 0.75 nanograms per ml per year is suggestive of cancer. And there are two types of PSAs. You have BPSA, that is the nicked type, and IPSA, that is the intact PSA. These are raised in benign conditions, whereas pro-PSA is raised in cancer. So these are all high yield points which have not been asked till now, but especially for your SS exam and INI CET exams, these points you should remember. Now, once you've done this, these patients, when you're doing a workup, you can even carry out a uroflowmetry and bladder pressure measurement in these patients. So uroflowmetry basically tells us about the urine flow rate. And accurate measurement can only be done if more than 100 cc of urine is voided. If more than 100 cc of urine is voided, then only we can get an accurate measurement. Otherwise, we don't get an accurate measurement in these patients. Now, if the urine flow rate is less than 10 milliliters per second, then it is suggestive of bladder outlet obstruction. Then it is suggestive of bladder outlet obstruction, or there is obstruction present. 10 to 15 milliliters per second is equivocal, and more than 15 milliliters per second is considered as normal. Bladder pressure measurement can also be done, and bladder pressure measurement, if the bladder pressure is more than 80 centimeters of If it is more than 80 centimeters of water, it is considered as high bladder pressure. If it is 60 to 80 centimeters of water, then it is considered as equivocal. And less than 60 centimeters of water is considered as normal bladder pressure. Now, how does this uroflowmetry and bladder pressure measurement help me? So, it helps me in differentiating two conditions. It helps me in identifying bladder outlet obstruction, or BPH, versus a neurogenic bladder. Okay. So in bladder outlet obstruction, or BPH, there will be increased bladder pressure. And low flow rate. There will be low flow rate. Whereas in neurogenic bladder, there is very low pressure, and there is low flow rate. So that is how we can differentiate a bladder outlet obstruction from a neurogenic bladder, by doing these uroflowmetric analysis and the bladder pressure measurement. There is another term which is mentioned in Bailey and in the urology textbooks as well, and this is called Marion's disease. Or prostatism sans prostate. And this basically happens due to the hypertrophy of the internal sphincter. And this is seen in young patients, where the clinical features are that they will have LUTS, they will have features of lower urinary tract symptoms, but prostate is normal. So that is prostatism sans prostate, or Marion's disease. And this was the workup of a patient with prostatic symptoms. Now that we've discussed the workup, let's talk about the two main pathologies, that is benign prostatic hypertrophy and prostatic cancer. So BPH, or benign prostatic hypertrophy, or some people like to call it benign prostatic hyperplasia. And there is a huge debate, and people say that hyperplasia is a better term to use. So benign prostatic hyperplasia. Now this benign prostatic hyperplasia usually starts in the 5th decade of life. And there are two components of benign prostatic hyperplasia. The two components are the static component and the dynamic component. Now, what is meant by this? The static component of benign prostatic hyperplasia is mediated when testosterone is converted into dihydrotestosterone. DHT is dihydrotestosterone, and the enzyme responsible for this is 5-alpha reductase. Now, this dihydrotestosterone gives rise to stromal hyperplasia. gives rise to stromal hyperplasia, which is responsible for the static component. The dynamic component of benign prostatic hypertrophy is mediated by the alpha 1A receptors, which are present all throughout the prostate and on the muscle fibers. These alpha 1A receptors are there, and this gives rise to increased smooth muscle tone. There is increased smooth muscle tone, which is responsible for the dynamic component of benign prostatic hypertrophy. Now, when there is hyperplasia and this smooth muscle tone is increased, what exactly will happen in the prostate and in the urethra and the bladder? That is what I want to discuss. So this is a normal person where there's a normal prostate, normal urethra, and normal bladder. But when there is benign prostatic hypertrophy, first thing which you can see is that the urethral lumen is reduced. Urethral lumen gets reduced, and because of this, the prostatic urethra gets lengthened. The prostatic urethra lengthens, and there can be an exaggerated posterior curve of the urethra. So what is the significance? If there is an exaggerated posterior curve of the urethra, the significance is that it becomes difficult to catheterize this patient. It becomes difficult to catheterize patients with BPH, and you need a curved catheter, right? So I remember when we were doing our post-graduation, when we were in first year, ours was a unit where a lot of urology cases also used to happen. So for all other male patients, the first year postgraduate or the interns were allowed to catheterize. But if there was any patient with benign prostatic hypertrophy, I distinctly remember that the senior resident or sometimes even the consultant used to catheterize them because it was a difficult catheterization and they did not want any injury. So that is one of the significance which you should know. Now, because there is obstruction here, there is increased pressure in the bladder, and this leads to bladder muscle hypertrophy. There can be trabeculations, and it can also give rise to diverticulae. Because of increased pressure, there can be diverticulae as well. Also, this pressure can get projected to the upper urinary tracts. There can be hydronephrosis also in these patients. So, with the enlarged prostate, these are the anatomical changes which happen in the urethra, the bladder, and the upper urinary tracts. Now, we have already discussed the clinical features of BPH, or LUTS, which I've already told you. I've already told you the workup of these patients as well. Now, whenever a patient of BPH comes to the OPD, we calculate an International Prostate Symptom Score. IPSS is International Prostate Symptom Score. And this International Prostate Symptom Score helps us in deciding what management to start off the patient with, right? So if the International Prostate Symptom Score is 0 to 7, this is mild disease, and we start these patients with observation. No treatment is required, just observation is what is required. If it is 8 to 19, this is moderate disease, and usually these patients are started on medical management. And if it is 20 to 35, this is considered as severe, and these are the patients who require both medical and surgical management as well. Okay, so this is just a starting point to assess the patient and to start the treatment. Of course, it can be assessed at regular intervals to also see whether these patients are responding to treatment or not.